Thanks for being a sport, Jim. And I think that discussion was invaluable because, sometimes we just give our slides, present it, and then say next speaker. So I think discussion is extremely important in meetings like this. So let me see what we can do to elicit a discussion on thoracic endografting. I think Dr. Criado presented on intramural hematomas. Go to the next slide. So this was the case we had originally planned for the meeting. And you see he had like almost a 6-centimeter arch, almost an arch distal aneurysm, and we were planning to do a single branch, but the patient needs a cabbage. So that case is nixed for now. But luckily, Dr. Westerban, who is also a partner in our group, was doing a case, and he was kind enough to say, let's do this live, and I'll have him present this particular case. Go ahead. Next slide.
So this is a 75-year-old woman who was brought to the emergency room following a low-speed single vehicle accident. She was a driver, and she hit her chest against the steering wheel. So upon admission, her blood pressure was 160/90, and she complained of chest pain. She had essentially no other symptoms. Her past medical history, she has a history of hypertension, a chronic thoracic back pain, although she said it wasn't that bad. And she was actually admitted to another hospital last year for thoracic and abdominal pain. She was worked up, and then other than that, she had a perforated cheeks, a hysterectomy, and she still smokes about 5 cigarettes a day, but she used to be a heavy smoker. So a CT of the chest was obtained, which showed a penetrating thoracic ulcer in the descending aorta.
Distal descending.
Distal descending.
So the patient again, I think, got readmitted again with back pain, and then the decision was then made, I think, Alex, to treat her because of recurrent admissions and similar pain. So obviously, I'll ask the panel, what are the indications to treat a penetrating ulcer of the thoracic aorta?
If it's there, you treat it.
How big does it need to be?
No wonder you got
before
this
treat it?
Lifetime Achievement Award here. 2.5.
How big, Ron?
Well, the guidelines are a couple of centimeters, wide or a centimeter deep.
Yeah, so the guidelines,
this
if
is
you look
big
at
enough.
the indications to treat it, yeah. So the indication, and plus, twice admitted in another hospital and then again here. And so Dr. Westerman had already decided to treat it. And I sort of told him that this would be a good case to elicit a discussion because you see, even in the abdominal aorta, we treat a lot of penetrating. So if you look up indications, I think the data says, and Dr. Koselli and Orania and all can talk about this, is that penetrating ulcers, I think, should be at least greater than 2 centimeters and a depth of 15 millimeters. And of course, symptomatic and dissections and intramural hematoma around the penetrating ulcers are all added features of when you would fix it. So the decision was made, okay, Alex is going to fix it. So Alex, what do you think? Would you put a spinal drain in this patient?
Yes, decided for a spinal drain, especially considering the location of the ulcer, which is about at T9, T10. In the literature, they say 25% of them get a spinal drain, not all of them, but in this particular case, I thought it would be a great idea.
Rod?
Yeah, I'd put a spinal drain in this patient too. So I think, but it's because of the
patient has a
location,
spinal
and
drain. We
you're gonna cover a critical part of the aorta, I assume.
Right. So then, of course, which stent graft and how we're going to do it. So we got access from the right side. Percutaneous puncture, put in two ProGlide sutures, and we selected a gold thoracic endograft. Alex, go ahead. We punctured the left groin, put in a pigtail catheter. We even did an intravascular ultrasound to see exactly how much and how little and how much we need to cover and get the best possible results. So if you play the intravascular ultrasound live.
So Venky, while that's playing, this is Dan Clare. So I'm not sure I would have put a drain in this patient because it's a very focal lesion, unless there was evidence of a really large intercostal there.
Yeah.
On the CTA, is there evidence of anything like that?
Yeah, right around the penetrating also, even in the aortogram, I thought we did see a fairly large intercostal. And the other reason why I talked to Alex
Right
and said,
there.
what are you putting, and this is Sunday. So if you do this and the patient becomes paraplegic, I have to call radiology. Unfortunately, anesthesia does not do spinal drains here, radiology does. And so when it comes to an emergency, then I think we lose time.
Yes.
So Alex made the decision that we will do the spinal drain, and if needed, take it off tomorrow. So that is
There they are right there,
large,
Venky. You
almost
can
like
see
a-
that. Yeah. There's
Yeah,
a
so
pretty
part
good-
of it is
Say
what's
that
your
again?
what's your system for getting the drain in, and we have actually almost like a code stroke team that we can call if this is a concern.
Yes,
right,
yeah.
right there. Yeah.
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 And people are
So,
now coming in
when I was
looking
at my
at
older look,
perispinal invos also and for oxygen saturation and only doing rescue drains. And they're getting good results. So, and I've certainly had a couple complications from a spinal drain, which are devastating.
Yeah.
yes, I've had one real bad one in all my career so far with spinal drain. So yeah, there's a pros and cons, and there are dangers of putting in a spinal drain. And the decision was made, let's do this. And we have a really good radiology department, but it's not like we could get them immediately and things like that. So we did put a spinal drain. The spinal pressures are being monitored. I don't know how many of you have this automatic, what is the system called? They have this spinal drain that sort of, what is it called? Yeah. Do you use, which spinal drains do you all use? I think Dr. Stoner is going to present about spinal cord ischemia and changes in management too. So, okay, so spinal drains in, we did an intravascular ultrasound, we had good access, we got a 20 French dry seal sheath in, and show me the aortogram. Can you see this picture?
Wait, why do you have access
So
in
that we
both
know
groins?
exactly. It's true, well, that's not a bad point, because sometimes through the go dry seal, you can even put a pigtail, and you can do it all with one access. But I think, knowing exactly where the graft is, if you want to take additional pictures, then I think having a pigtail on the other side for troubleshooting is good. And more importantly, when we remove that sheath, and if you do have any problems, we got an access to go up and over in case you need. So yeah, you're right, Rod. We used to do it all through one incision. But I think, when access is tight, or if you have other issues you think you may have with access, then just keeping the access on the other side is good, and it allows you to shoot repeated pictures as you're deploying, especially if it's a very accurate landing zone that you need to deploy. So that's the aortogram. Okay, Alex has now put in a Gore endograft. We sized on IVIS based on CT. We selected a 28 millimeter.
So we have a 15% oversize.
Okay, so let's go live now. So to the Gore dry seal sheet, we have an image of the roadmap. I don't know whether you can see both screens. I generally do this, like I said, on the roadmap, and you can see the graft is seated 2.5. Let me see. Go a little higher. Turn the screen here this side. Alex, what do you think? Anybody like that?
Right there.
Okay.
I'm sure.
Okay.
So it looks like.
So we're going to deploy this. This is the Gore graft, and then we're going to pull the stage 1 here. There's the graft.
So this
And
deploys
that's
from the
simple as
bottom
it is,
up,
I
right?
guess, huh?
Yeah, we can't see it.
Yeah.
Barely.
There you go.
Give us a little bit of.
Okay, so then finally, we're going to take this.
So it's partially
So the Gore
deployed.
graft is completely deployed.
You could still move it if you wanted to, right?
Yeah, I can still move it.
Pull it back hard, Vinky. There you go.
It got jammed in there. So I had a device like this. Actually, I pulled it down, because it got jammed so badly. But again, you got to be careful. There are no simple cases. Everything is. So now the pigtail is obviously behind the graft. So we'll put the pigtail back in. Alex, let's do that. Go ahead. Put in a stiff glide wire.
Ted would be very proud of your blue towel technique here too, Vinky. So you get commended for that.
In fact, one thing I have to say, and I didn't say this and I should say it more often, is Chris Woolley and the team, we call them the VAS team, and these phenomenal people who do AV. I started right from Arizona Heart. If you remember, Rod, the first employee that Dr. Dietrich hired was not a doctor, was not a nurse, was not a manager or administrator, was a cameraman, Dick Williams, and we honored him last year. And so, yeah, when you do these live cases, most of the time I'm like this, even on a normal routine OR too. No blood loss at all, basically covered up everything, but still. But again, for in terms of visual cleanliness and reception and how you look at things, I think the VAS team is excellent. And so we've used them for almost, 1997 since I started. And they do a phenomenal job, and they're extremely busy all over the place, all over the country, doing live transmissions of live cases. Okay, so Alex has got the pigtail through the graft and above, and let's take a picture. Can you hold respiration?
Why are you going to take a picture?
That one's been
Why?
Yeah.
I would flip it and say, why not?
I know
There you go.
there is a small incidence of endoleak according to some of the data.
Okay, play that again. So let's see, the graft is about 1 to 2.5 centimeters in the proximal landing zone. That's decent neck. And distally, it's right exactly, make that a little darker, please. Distally, yeah, and you see there's no flow going into that. Yeah, we can do a repeat IVIS just to make sure that the graft is not crimped, the apposition is good, and we can actually do that. Let me take the delivery system out, go live. Like I said, they have not put in all the images of the site. The other thing I would like to say is even when you're dealing with the distal aorta, you see that wire at the top? That is your marker because you do not want to lose sight of that top wire. That could go into the carotid, it could go into the subclavian. So, simple procedures can be associated with a fair amount of complications in certain cases like this. So make sure your wire is constantly visible at all times at the top in the ascending in the loop. Let's repeat an IVIS and see how the graph is. We do have side R, but let's do the IVIS also.
So you're going to IVIS it now, is that it?
Yeah, I'm going to put an IVIS. Keep going, we're in the sheath now. Yep.
Sheath looks pretty good.
Okay, keep going up. Keep going. Go through the graft, keeper. That's well up. Go right to the top and do a pull through. Yeah.
Lumbars.
Okay, so that's native aorta. You can see the pigtail over there. And slowly come down now. As you come down,
Yeah, I don't think they hit him.
you will see that's the beginning of the graft. It's well opposed. Push it back up.
Dan, you may be right. I don't think
Native
they
aorta.
covered those vertebrals.
And it looks good. Looks good.
Yeah, with the air in the
Opposed and now
graft,
the
you don't
distal
see
landing
well,
zone.
but
Yeah, you can't see too much well here, but you can see it's push it back up. So there's no kinking. There's good wall apposition. So I think we're done. Obviously, I won't show you the access, but but the access was really good. So I think the discussion is again. I think the controversial part is when do you fix these penetrating ulcers, intramural hematomas, which is again another one. And then, of course, all the type B dissections and expanding false lumens and things like that. So thank you, guys. Before I sign off, I want to thank this entire team here. It's not easy to get staff working on the weekend. Special thanks goes out to Dr. Cohen, who's our anesthesiologist, who we've really protected from radiation today. And, of course, the entire radiology team. Bernie is our scrub tech. He's here from Arizona Heart. He's our right hand. Alex Westerband is my partner. This is Bernie. This is Stephanie Wilson, who's made beautiful slides and presentations. And then, of course, Lauren, Jess, and the entire team at the Honor Health Network. Thank you, and I'll see you soon.
Well done.